Hello and good evening. It's good to be back. Please let me know that you can hear me loud and clear as we will start another IVF webinar. And hi, Dr. Nadia, how are you feeling today?
Very well, thank you. Good evening to everybody.
Good evening, and again, thank you so much for joining. It's a pleasure always to have you back, and I'm very glad that you have decided to come back here again and present such a topic. And of course, well, I am definitely happy to hear to see you here. And as always, as you know, let me just remind about a few rules. So first of all, we will start with Dr. Nadia's presentation, and after that, it will be time for your questions. So as always, you need to put them in the chat section so that Dr. Nadia can help you out. And of course, just let me introduce Dr. Nadia. So she is the head of the international medical team at Equipo Juana Crespo. So if you don't know her already, it's our, I think, third webinar. So welcome back as well. And as I mentioned, she will be able to answer all of your questions later on as well. And as always, please let me remind everyone that all the Stronger Together events have been brought to you thanks to our ambassadors and partners, and you can see them right here. There's a huge bunch of people that are involved in this Stronger Together, and as you know, we were rewarded for that as well, for all those IVF webinars, and Dr. Nadia as well was part of it before, and I am very, very happy that you are back with that initiative for the second edition.
Thank you. Thank you so much.
Thank you so much as well. And well, it is recorded, so remember you will have a chance to watch this again. And now we will start with the presentation on our topic today, which is unexplained infertility and IVF options. So Dr. Nadia will talk about treatment process and also diagnosis. So Dr. Nadia, are you ready to begin with your presentation?
Okay, thank you very much, Caroline. Good evening to everyone. As Caroline introduced myself, I am Nadia Caroppo. I am one of the members of Equipo Juana Crespo in Valencia, Spain, and I'm the head, the coordinator of the international department, together with Dr. Alejandra Aguilar. Today's topic, it's a very important topic because lots of couples come in with failed IVF treatments, and sometimes they do not have answers to their questions. And we have some experience in what we call unexplained fertility, and you will see as the presentations goes on, why we are just discovering what that means. Okay, so it's true that chance explains 2 out of 3 cases of implantation failure. It's true, okay? But what happens with that third part, that it's not, there's no explanation, okay? If we have repetitive IVF failures, yes, of course, it can be a random failure, but the ones that have a cause, okay, may be based basically in embryonic problems, okay, being one of the most important parts of the IVF failure, um, others due to bad simulations or bad uterine preparations, and other causes are included in other causes, thrombophilias, etc. But we know that there are, for example, a thrombophilia, that's a problem of the coagulation with a blood coagulation cascade. It may not be a formal cause, okay? We sometimes see that if we have biochemical pregnancies or recurrent miscarriages, sometimes we forget about 2 things, okay? The uterus, that it's the best incubator we have. It's the utterly the undermined organ, reproductive organ, we tend to discover, and the fallopian tubes too. And this is because, of course, we have some issues, okay, that can involve their functionality, okay, and that is why we believe in a personalized medicine, okay? Why? Because I am not the same as any other women who come to the clinic, okay? And we need to understand what is going on wrong with each woman and each couple, okay? Just to give them a correct approach to their problem, okay? And to understand where fertility comes from, infertility comes from, and to know which path we have to just undergo. So here you have two graphs, okay? That the first one on your left um, shows the conception period for natural pregnancies to occur, and this was a study that was done in postpartum women, okay, that it showed that 65% of super fertile women, okay, the fertile couple was what normally occurs in nature, okay, 65% of them got pregnant within the first 3 months of searching for baby, okay, and after 18 months the flatten from from 6 months to 18 months, okay, the curve, yes, um, increased, but it tended to flatten, okay. The same thing happens with oocyte donation, okay. We see that after 5 embryos transferred, okay, 65% of the couples get pregnant, but after that, the more embryos I transfer, the curve still flattens out, okay? And this shows that there is nothing like natural conception, okay? Of course, sometimes we have issues not having good embryos, good eggs, or we are in menopause, or whatever the cause of our sterility is, and we have to record to egg donation. But this is to show you that if for, the more embryos we transfer, the not more success we will have, okay, compared to a natural cycle, okay. So this is just to remind you that if we compare a oocyte donation, that it's like a a different standard, okay, where we can compare natural conception with oocyte donation, because eggs are good quality eggs and coming from young donors, okay, both graphs are comparable, okay. So what is happening when we fail with our IVF and we have no responses, and they just tell us, okay, we failed once, twice, 3 times. What is happening? Where's the cause? uh, what is not working? Okay, are my embryos not working? Are there other causes that may be influencing in a negative results? Okay, so what can be improved? Are my eggs good? My sperm, is my sperm count, my sperm quality good? There we can work on, okay, we can work in different ways, okay, just to improve oocyte quality and semen quality, just to select, for example, semen with fertile chip or adenosine columns, okay. Oocyte qualities is improved with sometimes we use coenzyme Q10, DHEA, that is an androgen for low responders, improving just environmental factors, food the intake, okay, lowering the doses, the intake of some like gluten, for example, or lactose that may influence in a negative result and give us a pro-inflammatory environment in which these oocytes do not have the best quality. We can improve with those things embryo quality. We can select embryos by PGD, pre-implantation and genetic testing, okay? But it's also very important to have a very good embryo transfer. Embryo transfers do not have to cause pain, do not have to cause bleeding, okay? And also we have to take care of our uterus and the fallopian tubes, okay? Because it's not just looking at an endometrial lining that it's good, true laminar, with a good thickness, okay? There are a lot of other things that sometimes are forgotten, okay? And the cause of my failure can reside eventually there, okay? So our unknown enemy, okay, are two things that are called endometriosis and adenomyosis, okay? So what is endometriosis? It's when the endometrial tissue, it's the inner lining of our uterus, that each month shows up with a period we don't have a pregnancy, okay? If that tissue resides outside of the uterus, being the fallopian tubes, the ovaries, the intestine, the peritoneum, bladder, okay? There are lots of women who suffer from endometriosis. They have a diagnosis because they have a cyst, for example. That's the most common diagnosis, okay? But some of them do not have that clear factor like a cyst, and then adenomyosis, endometriosis cyst that can give you the diagnosis of endometriosis. And adenomyosis is the presence of those endometrial glands in the stroma of those endometrial glands, okay, inside the endometrium, that invade the smooth muscle that resides in the uterus, okay, and cause hyperplasia. And that hyperplasia is a growing tissue that it's an ectopic tissue that does not have to be there, okay? So those two things are two items that have to be taken into consideration when we have failed IVFs. I'm sorry, failed IVFs, and we don't know the cause of our sterility. Okay, so we are going to talk a little bit about this and what we have to do to improve things. Okay, so there are lots of origins. Okay, not origins. There are a lot of theories. Okay, from where endometriosis can arise from. Okay, there is one genetic and epigenetic theory. It's we know if we investigate with family history, we know that lots of women who have endometriosis, okay, we just tell your mother, your sister, somebody in your family had painful periods, etc., etc., and you know that there's a pattern in this transmission of this disease, even though there is no gene that is correctly identified for this disease, okay, that it's benign but it's chronic, okay, and it acts reproductively speaking, it's like a cancer, okay, because it can undermine the function of every organ, okay, we have in the reproductive tract, okay. There are biochemical alterations and lesions and immunology and ambiental factors, also environmental factors, sorry, it was misspelled, okay, environmental factors that can change the expression of those genes and make my physiology change, okay, and cause an endometriosis, okay. There's another theory that it's the retrograde menstruation, that is when my period, just I see it coming through the vagina, there are some droplets of blood that travel through the fallopian tubes, okay, and can invade other organs. Let's say the ovaries, okay, the peritoneum, the intestine, the bladder, okay. That is one thing that also collaborates to the origin of the endometriosis. Uterine biomechanics, okay, when there is a disruption of the subendometrial membrane, that is the membrane that separates the endometrial lining from the muscle, okay. For example, when we have very painful periods, our uterus tends to contract, okay, and that contractions is produced in pain, and that barrier starts to break, and some droplets of blood just get through that barrier, invade the muscle, and can travel through the blood or through the lymphatic system, okay, to other organs, and create this endometriosis, okay. Not only a painful period can alter that subendometrial membrane, okay. Also, we get a lot of patients who just get pregnant by themselves in the first, second attempt, and then they do not get pregnant anymore. Why? Maybe they had a long labor, okay, and that can disrupt the membrane because we are under contractions every 1 or 2 minutes we have contractions, and that uterus suffers, okay. Miscarriages, DNCs, they are all causes of endometrial and myometrial injury that can contribute to the genesis of the endometriosis. And the metaplasia is a differentiation of the endometrial stem cells into other cellular lines, okay, that we can see that these stem cells can, if they have different um, signals, okay, coming from endocrine patterns, okay, of signaling. They can change, and they can be eventually change into other types of tissues, okay, and this can contribute also to the endometriosis, to the start of the endometriosis. And our immune system and the environmental factors are very important, because this disease, being benign, it has an inflammatory basis, okay? And when we have inflammation, there is also a pattern to repair that inflammation, repair the tissue. And when we repair the tissue, okay, we create scars, okay? And scars are not good, okay, in the long run, when we are talking with for on the behalf of uterine functionality. So that can give me superficial endometriosis, cystic endometriosis, deep endometriosis. Deep endometriosis is when I have all my anatomy just changed, because I have deep nodules of endometriosis being and organs can be stuck together, okay, and that can disrupt my fertility, okay. Cystic endometriosis is the most common thing. The superficial endometriosis is a stage, an early stage of that endometriosis, and it can be seen maybe not echographically, okay, but when we do a laparoscopy, we see like small lumps, cystic lumps on the surface of the uterus, on the fallopian tubes. And we also know that when we have endometriosis, we can have adenomyosis, and I will talk to you about that later on, okay. So endometriosis can alter everything, okay, my whole functionality. I can have altered embryo quality. Okay, so we have, when we do a diagnosis of endometriosis, we have to know how to improve egg quality. Okay, we have to know if we have to undergo a surgical treatment to treat that endometriosis. We have to know how to restore functionality to those ovaries, for example, or to those uteruses that are affected by endometriosis. Okay, there's no point taking away a cyst. Any gynecology can do, a gynecologist can do a cystectomy. Okay, but we just have to think that we are taking away a piece of tissue. Okay, a healthy tissues just disrupted with that cyst from the ovary, and I'm taking away some good follicles with that cyst. So we have to clearly understand how we have to restore the morphology and the functionality of an affected ovary. For example, we have to personalize protocols, try not to alter the estrogen levels and increase them a lot, because this disease is estrogen dependent. So if we increase a lot estrogen levels, I'm just creating like a feedback, a positive feedback. The more estrogens I have, the worse the endometriosis will be. Okay, and that in the long run can have a negative impact in my final result. That would be not a negative pregnancy test and not having a baby. Okay, and labs, the embryology labs, have to be prepared to work with maybe bad quality embryos, okay, bad quality oocytes. So we have to have experienced biologists who know um, how to treat eggs with coming from women who have endometriosis. So this is the point, to understand the origins, to understand which quality we may have, and just go a step forward, just to know and give you some feedback before you get the results, okay, of the final um, stimulation protocol. Okay, and here we have endonomiosis. That adenomyosis, you see the picture there, it's a picture of the smooth muscle that covers the endometrium. Okay, that smooth muscle is functional muscle that contracts. It's normal for us to have contractions. Okay, what it's not normal is to have painful contractions. Just to make sense, to give you an idea, the contraction of the uterus, it's called peristalsis. Okay, so we have peristaltic contractions during the whole menstrual cycle. Okay, 1.5 peristaltic contractions. Okay, and we will have 10 million contractions during the first 10 years after the first menstrual period we get. Okay, and if we take a median of 30 years of periods, we will have 30 millions of peristaltic contractions. So this can be an origin, okay, of that unexplained infertility. Periods should not be painful. You should get your period and just say, oh, I just got my period because I stained my panties. Okay, that's normal. Okay, it's not normal to have pain. But I repeat that the adenomyosis and the endometriosis can have also an origin in other um, factors, just like I said before, long labors, very very long and difficult explosive periods of the babies, okay, forcible births, C-sections, myomectomies, okay, even if you have undergone an appendicitis, okay, that it's a pro-inflammatory disease that can undermine in the long run the functionality of the uterus in some people. Okay, we have to have some predisposition. That's not for that's not a rule for everybody. Okay, so what is the clinic? What do I get? How do I know that I have adenomyosis? Okay, how do I know that I have endometriosis? 30% of people are asymptomatic. A lot of women are just come in and tell me, okay, but I don't have painful periods. Okay, yes, it's true, but you may have that because maybe your thyroid gland is not working okay. You tell me that you have intolerances to other factors like gluten, like uh, gluten, lactose intolerance, okay? You have some other immunological diseases, okay, that can be linked to everything, okay, to endometriosis and adenomyosis. Adenomyosis can also have another manifestation that's an abnormal uterine bleeding. You bleed in between periods, okay? You can have spotting. Before your period, after your period. Most women have pain, chronic pelvic pain, okay? They can have pain with intercourse, or they have dysmenorrhea. Dysmenorrhea is are painful periods, okay? And lots of them have reproductive failures, okay? And that's in the long run what we are more keen to diagnose, okay, because most couples come in and they tell us, okay, we've done 3 IVFs, 4 IVFs, or we've undergone also egg donation and we have failed IVFs. What is happening? Where's our problem? Okay, so that's one of the causes of unexplained fertility. Okay, so uh, the in regarding reproduction, okay, adenomyosis affects our reproductive tract because there is a disruption and a dysregulation in the architecture of our uteruses, okay, um, being that walls become a little bit thicker, harder, okay. Some women just tell us that they have have had in the past um, 5 or 6 days of menstrual period, and in the long run they just have 1-2 days of period. Pain was worse before, and in the long run pain was much more tolerant. They were more tolerant to their pain, okay. And that's because the functionality of the uterine walls is worse, okay. It's not as elastic, that uterus, as it was in the past, okay. And we can have also altered endometrial function, okay, because as it is an pro-inflammatory disease, sometimes the endometrium does not work as it should, okay. So this is how it can affect. So adenomyosis and endometriosis are progressive benign diseases that can change their appearance, their morphology throughout time. So there's no certain pattern of, if you see this, it's adenomyosis. If you see that, is endometriosis, okay. You have to understand how both diseases work, just to see what you have to find out, okay. It's not the same an adenomyosis in a woman being in her first 30s than in a woman near her 40s, okay. They behave totally different, and what you see in ultrasound, for example, it's totally different, and the functionality is different, okay. So you have we have two subtypes of adenomyosis, but this is a little bit technical, okay. The one that it's caused by trauma, what I told you about the contractions we have, okay, and it resides below the endometrial lining in the subendometrium. That involves fibrosis, okay, like a very hard tissue below the endometrial lining, okay, and the subtype 2, that it's the outer endometriosis, that it's more linked to endometriosis, okay. So if we see manifestations of adenomyosis outside, near the outer part of the uterus, probably we will have also an endometriosis, and it affects the functionality of the uterus in a different way, okay. So that is why both things can coexist, okay. So the prevalence of endometriosis in adenomyosis, it's an 80.6%, and the prevalence of adenomyosis in endometriosis is 91%. So you see that usually we find both diseases in one same patient, okay. So it's very common to make the diagnosis of both things in failed IVFs in the past, okay. So what are the risks of adenomyosis? How can it affect eventually a pregnancy, okay. This accounts also for endometriosis. We have a higher prevalence of miscarriages, preeclampsia. Preeclampsia is high tension, high blood pressure during pregnancy, okay, that may lead to eventually preterm births, okay. Placental malposition, being that the placenta, instead of implanting in the fontical part of the uterus, okay, just implants in the lower part of the uterus, and you can have placenta previa, okay. Preterm births, because they are harder uteruses, they tend to stretch a lot less, okay, they are less functional, and the placentas have the embryos have a hard time just scratching in and implanting in adenomyotic uteruses. So sometimes babies are a little bit smaller for the gestational age, okay. You can have cervical incompetence. Cervical incompetence is when the cervix just loses the functionality, just stay closed, okay, and well formed, and it just lets itself go, and you can have immature births, okay, like around the 18th, 20th week of pregnancy, okay, and it can lead also to chorioamnionitis, that it's another complication, okay, that it regards the uterine infections, okay, and the alteration of the normal flora we have in the uterus can also be altered because of this pro-inflammatory disease called adenomyosis and endometriosis. So uterine functionality, we see two types of uterine uteruses. Usually the hyperfertile uterus that will get pregnant of anything, okay, but it's a very receptive uterus, okay, and that uterus maybe will have lots of miscarriages because maybe he or she the uterus gets pregnant of any embryos that passes by, good embryo, bad embryo, normal embryo, abnormal embryo, okay. So you have on the one part the hyperfertile uterus, and the other part the hostile uterus. Hostile uteruses are the ones that are more affected by these two diseases, okay? And there is where we have to do a good selection of embryos, good selection of treatment of those uteruses just to restore normal functionality to them, okay? So implantation is not a passive process. We know that there's a crosstalk between the embryos and the uterus, okay? And we know that very good embryos have a higher chance to implant. And maybe bad embryos, just when we decide to transfer two embryos, one being very good and the other one being a lower quality embryo, they just help each other. There's a cooperation, okay, and there's a cooperation also with the endometrial lining and the uterus. There is a lot of secretion of the implantation is mediated by inflammation and by immunology and by the endocrine and paracrine system, okay. So we have it's very complex. We know that each embryo has its own messages, but it's true that the crib, okay, that it's the uterus, has to be correctly treated just for the embryo to implant and to understand himself with the endometrial lining and with the uterus itself, okay. So how do we know how do we make the diagnosis if we have adenomyosis or endometriosis. We have two types. We can assess for morphology and functionality. Okay, morphology is usually assessed by the ultrasound and pelvic MRI, and the functionality is what we see when how the uterus behaves during, for example, stimulation. Okay, we can assess it with if the thickness of the walls get a little bit the walls get a little bit thicker than usual. If the endometrial lining just bounces, okay, during stimulation, that may be a sign of endometritis. If we see a white uterus, that is fibrosis. Okay, we have also other things that can contribute to assessing the functionality. That's the video MRI that assesses those contractions. It's very difficult to make a correct diagnosis with the video MRI, okay, because it's very difficult to understand if it is a contraction or if the membrane that separates the endometrial lining is thick because of the adenomyosis itself. Okay, so we base ourselves to do these diagnoses with pelvic MRI and the 3D ultrasound. And of course, we have another diagnostic tool that it's hysteroscopy. Okay, I will talk to you about that later on. Okay, so you have um, some pictures here that show altered altered uteruses. Okay, on your left you see the optimal 2D pattern, okay, in the ultrasound, a perfect trilaminar endometrial lining with symmetrical walls, okay, and all the other pictures, okay, especially where you see those black spots around the endometrial lining, that is cystic adenomyosis, okay, it's a very active adenomyosis, okay. The first picture, okay, you have starting from your left in the suboptimal pattern, you have three black balls, okay, of adenomyosis and a very thin endometrial lining, okay, that's a very hard uterus, okay. The picture underneath it, you see that the endometrial lining, it's somewhat trilaminar, okay, but the walls around are not good enough, okay. So those things are things that we can assess during the exploration, okay, and to perform diagnosis. In 3D pattern, we usually see the morphology of the endometrial of the uterus or of the uterine cavity. I'm sorry, okay, and we can assess also sometimes the subendometrium if it's very thick or not. Okay, it depends on the cut and the moment we do of the cycle. We do this type of diagnosis. Okay, sometimes the inner shape of the uterine cavity changes throughout time. For example, it can get to be a T-shaped uterus, as the T that you see below, okay, or a Y-shaped cavity, okay, and that talks to us also about the type. If I believe that uterus is a little bit harder than usual or not, okay, so that's something that we also have to bear in mind, because the perfect shaped cavity is a triangular cavity, okay, just to keep that in mind, okay. And we have hysteroscopy. We can assess lots of things, okay. We can assess the endometrial lining. The endometrial lining has to have that pink, just cloudy sensation, okay, as the optimal hysteroscopic pattern that you have. Then you can have endometritis, okay. Adenomyosis can affect my cavity because it can stick the walls, okay. Consynechia cause caverns, okay. And you see when you open the caverns, you see that like brown blood comes out from them, okay. So there are a lot of things that can be assessed through hysteroscopy, and we can treat also adenomyosis, very hard uteruses. We can treat them with hysteroscopy too. So it's not just a diagnostic tool, it's also an operative tool just to make sure to repair that uterus, okay. The pelvic MRI you see on your left is the optimal pattern. The black lining that you see You see the white part where the asterisk, okay, that's the endometrial lining. The black part is the subendometrium, okay, and the other part is the uterine walls, okay. So you see what a differences we have, which differences we have in a perfect uterus, okay, that gets pregnant, and with the uterus that have lots of adenomyosis, okay. All the circles that you see, for example, in the first picture, okay, you have white cyst and a very thick uterine wall. That's a very bad endometriosis, adenomyosis, such as the third one, okay, on your right, okay. Just underneath that, you have a disrupted subendometrium, and that recalls for a very hard one of the walls is very hard. The lower part, where you see that the membrane is just intact, it's the good part. So we have to know and understand how to direct embryos to that part of the uterus, okay, so that we can do that, help ourselves with the hysteroscopy, okay, and also with medical treatments, okay. Hysteroscopy, surgical treatment, it's not the only treatment, okay. Sometimes we have to combine surgical treatment with medical treatment, depending on each on each case in particular, okay. Or you can use analogs that are anti-estrogens, the Femara that we also use for stimulation processes, okay. We can use the IUDs that liberate progesterone, such as Mirena, or just pills, the mini pill, okay, contraceptive pills that have only progesterone pills, okay. We have lots of things, okay, and depending on each case, we will need either just hysteroscopy, we will need hysteroscopy, laparoscopy, sorry, just to remove masses of adenomyosis. But just for you to understand, um, the surgical treatment, very radical treatment of adenomyosis, is left just for very, very particular cases, okay, because it's very difficult to operate on those uteruses, just thinking about restoring functionality, okay. And sometimes we do that when there's no option left and there's nothing to lose, okay. We've tried everything and we just go in and try to restore the normal shape, normal functionality of that uterus, okay, with laparoscopy or laparotomy, okay. So depending on each case, we have to decide which treatment is best, okay. So there's no just one treatment for this, okay. So you must know that, just for you to understand, we have to learn we learn from you, okay. We learn from the moment that you step into the consultation room, and the moment that you start the stimulation, and the moment that we see how your uterus just behaves, okay. You give us a lot of information, and that, together with the ultrasound, together with the pelvic MRI, together with the hysteroscopy, we can just try to make account for better results, okay, and study and give it a turn in a key point, okay, in your history, just making a correct diagnosis, okay. We always learn from our own failures, okay, and sometimes we thankfully sometimes we got to learn a lot from failures coming from other colleagues, because it's very difficult. They are very subtle diagnosis that we tend to do, and it's very difficult if you're not trained to see endometriosis or to see adenomyotic patterns. It's very difficult to rule them out, okay. You just see it with when you have a very severe case of adenomyosis or endometriosis, okay. So don't be just keep your heads up, okay, and just try to focus on a specialist that has training in seeing these things, okay. There are lots of clinics, there are lots of gynecologists who know how to detect these things, but it's difficult. The most difficult part of all this is just to know how to treat it from the reproductive point of view, okay. So I hope this presentation has been enlightening for you, okay. And I hope I have given you a lot of information now, just to see if something of this has happened to you, okay, that to know that there's light out there, okay, and sometimes we can help you a little bit more, okay, just to see if we can make things a little bit better for you. Okay, I'm ready for questions now.
Thank you so much, Dr. Nadia. As always, you've been very thorough with your presentation. Lots of details you have provided, and as always, it's been, I'm sure, useful to everyone here. Thank you so much. And
Thank you.
yes, you are very right. It is time to start our Q&A session, and as you can see, a lot of questions are right here as well.
Yeah.
So let's have a look at the
Okay.
very first one. So how often is adenomyosis or endometriosis the cause of infertility?
How often? That's a tough question because in our clinic, like 95% of our patients have endometriosis and adenomyosis. The fact is that the younger you are, the less will affect you if you have endometriosis. Okay, so if you get pregnant, for example, if you have endometriosis but you are in your mid 20s or your in your first part of your 30s, okay, you may get pregnant by yourself, and maybe the difference between us, okay, that have endometriosis or adenomyosis and our mothers or grandmothers, okay, is that they got pregnant being very, very young, and maybe they had endometriosis, they had adenomyosis. But the younger you are when you get pregnant, the better the prognosis. So in our clinic, I can talk about in our clinic, we have a 95% of incidence of endometriosis and adenomyosis, okay? And that's a cause when you don't have any cause, okay? That accounts for 30% of all patients with unexplained sterility, okay? In general, okay?
And wonderful. Thank you so much for explaining this question. And there's another one from Katia as well. So let's have a look. To which degree do they lower my chances of a successful IVF?
As I told you before, it depends on a whole bunch of things, okay? It depends on how that endometriosis has affected your ovaries. If we see that the ovaries do not have a good follicle count, or that the follicles have not a good regular shape, okay, if we see that the ovaries are very fibrotic, okay, that may account for lower quality eggs and embryos, okay, quantity too, okay, so that can account for a diminishing percentage, a lower percentage in IVF success. And as I told you before, it's not only an embryo problem, okay? It's a whole problem that has to be evaluated. So if you're not correctly treated, the chances will get lower and lower. It depends also on age, okay? So there's no one, not a perfect percentage just to tell you a 10%, 20%. It depends on a lot of factors. But yes, Katia, it can diminish your chances to get pregnant.
All right. Understood, of course. Thank you so much for the clarification to this one as well. Okay, and let's have a look. Next question is, what vitamins should I take to reduce endometriosis, and for how long should I take them before my round of IVF?
Okay, Talia, this is a good question. Okay, we usually give coenzyme Q10 in 600 milligrams per day. Okay, myo-inositol. We advise to lower myo-inositol from 4 milligrams. I'm sorry, per day. We also give some preparations accounting for multivitaminical preparations, omega-3, DHAA. We advise to lower the intake of gluten and lactose for at least 4 to 6 weeks before you undergo an IVF. Okay. It's not to reduce the endometriosis, it's to reduce inflammation, okay? And usually you also give probiotics, and we are finding out that curcumin, okay, it's also a good anti-inflammatory compound that can increase my quality, okay, if I have endometriosis.
And again, thank you so much for this. And next question is, what are the main reasons for a missed heartbeat with a successful implantation? I recently lost an 8 weeks There was no cardiac activity. I had Asherman syndrome and was successfully treated for it in 2019.
Okay. First of all, if you have an Asherman syndrome, we have to understand if that Asherman syndrome was provoked because of other miscarriages, DNCs, or other some other surgical procedures. Okay, if that Asherman syndrome is provoked because of adenomyosis, that's a very difficult uterus to treat. When embryos implant, there are two waves of implantation. Okay, the first wave of implantation is when the embryo attaches to the endometrial lining and starts scratching in, that it's around 4 to 5 weeks. Okay, and the second wave of implantation is around the 6th to 7th week of pregnancy. Okay, and that accounts for the scratching into the uterine muscle. Okay, if you have the heartbeat of an embryo stops beating around those weeks, we have to know, first of all, if it is a normal or an abnormal embryo. Okay, because if you are miscarrying a normal embryo, probably the reason is because of a bad uterine functionality, a hard uterus. Okay, so maybe the treatment that you received in the past is not sufficient. Okay, just to make you have a successful pregnancy. Okay, so a hard wall. Okay, just you have to understand that if an embryo finds itself with a concrete wall beneath it, okay, the scratching process can be altered and the heartbeat can be stopped. Okay, it may account also for other factors, not only adenomyosis. Okay, sometimes thrombophilias have to be ruled out when that happens uh, several times. Okay, but you having an Asherman syndrome, maybe the uterine functionality is not the best one. Okay.
And wonderful. Once again, thank you so much for that. And of course, more questions are coming up. What can I take before my next transfer to promote optimal lining receptacle?
Okay. That is, we usually prepare the endometrial lining uh, or in natural cycles or in substitute cycles, and we usually give oral probiotics. Okay, just to make sure that the normal microbiome, okay, the normal flora of the uterus is obtained. Okay, we give oral probiotics generally. You can have also vaginal probiotics. Vitamins, regarding vitamins, sometimes we use vitamin A and E. Okay, but we stop them once we have a positive pregnancy test. Okay, it depends on if the endometrial lining is correctly growing or not, the thickness. It depends on a lot of things. Okay, so there's not one thing we do usually give. Okay, we give those. Sometimes we give those. Not sometimes. The probiotics, we always give them to our patients, and the vitamins too. Okay, we usually give them.
All right. Again, thank you so much for that. And well, there is a also, as you can see, question. Have you heard of coenzyme Q100, possibly, or 10, possibly, right? Or CoQ30 supplements?
30.
Yeah.
Yeah.
Anything
Yes.
you can
There are
share?
lots of Jocelyn. Thank you for your question. There are a lot of compounds. Okay, the studies show that generally with 600 milligrams you can improve egg quality. Okay. What coenzyme Q10 does, it acts on the mitochondria. That the mitochondria it's the engine of the oocyte. Okay, so you will find preparations in different milligrams, okay, in different dosages. Okay, so it doesn't matter if you have 6 tablets of coenzyme Q100 or coenzyme Q30. Okay, just to arrive to 600 milligrams. Okay, there are more pure forms of coenzyme Q10. The one that you will get will be the best. Okay, so the recommended dosage is around 600 milligrams.
All right. Perfect. Thank you so much for explaining this as well. And what about PCOS and the impact on the unexplained infertility?
Okay, good question, Emma. PCO patients tend to have lots of estrogens, okay, because they have lots of follicles, and each follicle accounts for an increase in the estrogen levels. So sometimes we see lots of patients who have polycystic ovaries and they have painful periods, and that may account for adenomyosis, okay, and a bad uterine functionality. But that has to be something that we have to just investigate, okay, because not all PCO patients have adenomyosis, okay. We see it a lot in patients who have had or surgical procedures before undergoing IVFs or miscarriages or whatever, okay, and also who have painful periods. Okay, so if you have those both things, you just remember that adenomyosis and endometriosis are estrogen dependent diseases. Okay, so if you have very high levels of estrogens, that may in the long run undermine uterine functionality. Okay, so yes, PCO may be related to an increase in the increased rate of adenomyosis if other things coexist, okay, such as pain, previous long birth, labors, okay, etc. What I explained before.
Okay, again, wonderful. Thank you so much for that. Next question is any benefit of endometrial scratching before IVF?
Okay, thank you for your question. This is a very controversial ask point, okay, in IVFs, in assisted reproductive technologies, because results are not concluded, do not show clear benefits uh, mm, when you perform endometrial scratching. Okay, there are a lot of papers which do not show any benefit, and other papers that tell that there is a 20% increase in the implantation rate if you do endometrial scratching. Personally, and in the clinic, we do not uh, do endometrial scratching. We do not believe that that's what improves in implantation.
Okay, again, thanks for that. And next question again, we have plenty more coming up. So, what are your thoughts about induced scratching? Some doctors claim that this inflammation helps implantation.
Okay, yes, it's just the question that
Yeah.
I have I answered. Okay, but we do believe that inflammation can help implantation, okay? But we do it in another way. We generally do it with hysteroscopy. We work the subendometrium in a different way, okay? We create inflammation just to make sure that we have new vascularization and new cells arrive to the subendometrium, okay? Superficial endometrial scratching, we have not seen any improvement doing that in the consultation room. Okay, we do that, we create inflammation when a hysteroscopy is needed to restore uterine functionality.
All right. Thank you so much for that once more. Okay, and there's a question about embryo glue. How about embryo glue? Anything you can add on that?
Embryo glue, we don't use it. Okay, we do not. There are some clinics that use it. That embryo glue, it's just a more sticky medium. Okay, just to make sure that it sticks to the endometrial lining. Okay, but that will not account 100% for an implantation. Okay, there has to be a correct endometrial lining. The embryo has to understand itself with the endometrial lining, and it has to be able to scratch into the subendometrium. Okay, so embryo glue may help, yes, but if the crib is not in a super shape, okay, embryo glue will account for nothing.
All right. Thank you so much. Next question is, can you spell the name of the probiotics you recommend?
Okay. In Spain, they are called Dona Plus Flora Intima. Dona with double N, okay, plus like a plus, okay, but it's spelled plus. Flora intima, and we give that 1 per day orally.
And wonderful. Again, thank you for providing those details. Sorry, I'm just checking.
Yeah.
Yeah, of course, there are more questions. I'm just checking if there is a follow up. No, sorry, I just thought that there is. Okay, next question, a bit longer one. I had an ectopic pregnancy 12 months ago with both embryos in the right fallopian tube, and since then I have experienced right-sided pelvic pain. I don't seem to have other symptoms. Is it likely this could be caused by endometriosis? Would you suggest I explore this, and if yes, in which way?
Okay, Karen. Ectopic pregnancies and biochemical pregnancies can have the same two origins. Okay, maybe the embryo, okay, just went to a part of the your uterus that in your case was the fallopian tube that had more inflammation, maybe because that fallopian tube did not work correctly or was ill from the first time. Okay, or ectopic pregnancies and biochemical pregnancies may account for some embryos who escape from the uterus because the uterus is not correct. Okay, the first thing I can recommend you is, if you did not have a right salpingectomy, is to do a hysterosalpingogram, that it's a radiograph, okay, an RX of the fallopian tubes when you inject a contrast inside, just to make sure that the fallopian tube has a normal caliber, it's permeable, okay, and that it's functioning correctly, okay. If you have had laparoscopy and your fallopian tube has been removed, okay, probably if endometriosis has been seen, okay, they should have told you something, okay. If not, I would suggest to investigate a little bit more your uterus, okay, your uterine functionality, okay. As I told you, the gold standard for endometriosis diagnosis is a laparoscopy, okay. For adenomyosis, you can have a 2D ultrasound, pelvic MRI, okay, and the correct assessment of an expert who can help you with that.
Thank you again for explaining this. And next question is right here. So, which vitamins with folate, not folic acid, should my surrogate take? Likewise, which probiotics, vitamin D, doses of each? What about organic flaxseed oils during pregnancy? Should she stay away from fish oils?
Now, fish oils, they are given in pregnancy, okay. Folate, there are a lot of compounds that there's an active the active compound of folic acid, okay, on folate, that it's called metafolin, okay, that it's the already metabolized metabolized folic acid, okay, that does not saturate the receptors of the folate, okay. So that's an option. Nearly all pregnancy vitamins have folates, okay. The dosage we recommend are 4 milligrams of that. Probiotics, there are a lot of probiotics. Lactobacilli are very important, okay. So you have lots of lactobacilli, Rasmusus, Ginseri, there are a lot of them, okay. I don't know, depending on where you live, sometimes you can find that in a whole in one preparation, okay. Vitamin D, if you have correct levels of vitamin D, that being 30 micrograms, okay, above 30 micrograms, you do not have to have another intake, okay. And it depends if you have a very severe deficit or just a medium deficit of vitamin D. We give different dosages, okay, of vitamin D. It depends. There are a lot of schemes, okay, that your doctors just will manage it regularly, okay. And the organic flaxseed oils, really, I don't know if you have to get them in pregnancies, because we don't use them, okay. We are not keen on using that.
Understood, of course. Again, thank you so much for that. And actually, we will go back to the previous question, okay, from
Yeah.
Karen. I did not remove the tubes. I did do HYCOSY and
High closing.
Yeah, thank you. But both tubes, but was not visible in right tube.
Both tubes, but the one right tube. Okay. First of all, hycosi, it's just injecting water, okay, and seeing with an ultrasound if the water just falls out of the tube. It's just drained from the tubes, okay. It's different from a hysterosalpingogram, okay? It's totally different. Hycosi does not permit you to see whether the tubes are dilated or not. If you're not, if the liquid was not visible in the right tube, maybe you have a blockage of that right tube, and maybe that right tube is ill, okay? So maybe it should be removed, okay? My advice is for you to do a hysterosalpingogram, okay, even if you did the hycosi, okay. One things does not account for, so they are not the same, okay, type of test.
Again, thank you so much for that explanation. And now let's go to a bit of a longer question. And again, there are like 3 questions left, so we will be slowly finishing. If you have any left, of course, what you need to do is just type those in the chat section. And the question has 2 parts. I've had 5 donor cycles, 1 implantation, but
A
miscarried at
miscarriage.
6 weeks, have had ER-MAP period blood test bacteria, had course antibiotics, EMA, analysis test, and ER-MAP receptive. Presumed immune issues, have had 2 cycles on prednisolone, aspirin, Clexan, tacrolimus, granoside, intralipids. Do you recommend any other treatment tests? And let me just put you this: had care, endo thickness around 8 millimeters on all transfers.
So Cass, you have a very strong um, story, okay, on your back. I think if you fail with 5 donor cycles, okay, and you had a miscarriage at 6 weeks, even if you have the air map, all the other things, okay, done, there's something else that is wrong, okay. And I believe that you have to search for some help, just to study your uterus from the another point of view, okay, because eventually your endometrial lining is perfect, okay, because of the thickness. Your air map is receptive, the EMMA and ALICE test are good, okay. So, and you had immunological issues that were treated, okay, regardless the care, the intralipids, the granulocyte, you got lots of things, okay. So I think that you have to be assessed from another point of view. If you never got a hysterosalpingography, just go ahead, do it. And if you have the chance to do the pelvic MRI during your post-ovulatory phase, just do it, okay, because it's very important to know if you have something else going on, okay, if your uterus is that receptive or not. I think that we are talking about a hard uterus, okay? We are talking here probably about adenomyosis.
All right. Again, thank you so much for your question and, of course, your help with that. And okay, let's go to the next question. So, what is the advantage and disadvantage of PRP therapy to improve endometrium lining?
Okay, PRP, it's very, now there are a lot of studies going on with PRP. There are no conclusive um, uh, recommendations, okay. PRP, what it's meant is just to take the growth factors that are produced by the plasma rich in platelets, okay, and the platelets itself. There are several ways of using that, just making an infusion inside the uterus or injecting it in the uterus. But we do not know yet the implications, okay? We have done some studies ourselves. We have used it. In some patients, it has worked. In some other patients, it has not worked. So we clearly don't know which is the indications to do it or not, okay? There are some studies also going on to try to rejuvenate the ovaries, okay, with PRP and make them more functional, but the results are not conclusive. So I cannot tell you the advantages and disadvantages, okay? It's not a very difficult process to do. It's just having your own blood sample, just processed, okay, and just infusing it back in certain times during your preparation. It may help, yes, it may help, okay. It cannot help, yes, also. So I don't have, I cannot enlighten you with a correct answer for that, okay, because this is, it's all under study right now.
And again, thank you so much for this question, indeed, as well as your assistance with that. And well, at least for now, it looks like this will be our final question. And so let's go to this: how long should one use prednisolone before and after?
It depends, okay. We just it depends the timing. We usually give it if needed during the endometrial preparation, just when we start the endometrial preparation. If we have a positive pregnancy test, um, we continue it, okay, until we see a heartbeat, and then we just start lowering the doses of prednisone, okay. So if you start taking it just when you are under preparation, it would be okay. We use generally 15 milligrams of prednisone, okay, when we start the endometrial preparation per day.
Okay, thank you for that. And two more questions are right here, so let's get to the next one. What happened in uterus if do not increase progesterone after transfer? What is a good value of progesterone after transfer?
Okay, Amelia. Prednisone levels should be above 10, okay, picograms. That's the rule, okay. And we see that under that number, we have the difficulties, okay, of getting pregnant. There are some women who get pregnant with lower levels, okay, but that's not the rule, okay. If you do not get a good impregnation with progesterone, you are not collaborating with the changes that the endometrial lining has to have to help the embryos attach and eventually implant. Okay, so it's good if you have to test for progesterone, just test it the day before, 2 days before the embryo transfer, just to make sure that the levels are above 10.
Okay, again, thank you so much for this. And sorry, yes, there's another question here. And which way can we improve the endometrial lining when it is too thin?
Difficult. Refractory, those we call, those are the most difficult and uteruses to treat. Okay, sometimes we give vitamin E, 400 milligrams per day, 400 units, sorry, per day. We can give Viagra, okay, also just to make sure that you have a correct um, blood reception, okay, in the subendometrium. We use pentoxifylline also, 600 milligrams every 12 hours. We also see inside the cavity to rule out that there are no synechia, Asherman syndromes, okay? And see, even if you have very thin endometrial lining, okay? See if the quality of that endometrial lining is good, because some women get pregnant even with 5 millimeters endometrial lining, if the endometrial lining is good. It's very difficult, okay? Sometimes we have to also do a hysteroscopy, not only to see the endometrial lining, but to work on the subendometrium, okay, just to create inflammation, new vascularization, and make sure that those that subendometrium starts working again. Okay, so it's very complex. It's very complex. It depends on what you have done before, just to know where we have to go afterwards.
And again, thank you so much for this, as always. Very useful. And next question is: do you recommend? Not sure here. Sorry, supplement.
I don't know what you mean by PQQ supplement.
Exactly. So, Karen, if you
I'm
could
sorry,
perhaps,
Karen.
yeah, please just explain what you mean. Okay. So I'm sure. Oh, okay. So let me have a look. No. So we will go for the next question. In the meantime, Karen, if you could clarify what you mean, so we can go back to this question. Okay. All right. And the question is:
Sorry, lost
Oh,
connection.
okay. Ask how long should one take prednisone, and if you could prednisone after transfer.
And is okay. After transfer, we give it up to the positive. If we have a positive pregnancy test, we continue with the prednisone until week 6 or 7. Okay, and after that, we diminish doses weekly. Okay, progesterone. We tend to use vaginal pessaries. Okay, of micronized progesterone. Okay, the natural progesterone, and we use intramuscular progesterone or subcutaneous progesterone to associate it with vaginal pessaries. Okay, depending on if you are on a natural cycle, we use 400 milligrams per day pessaries. If you are in a substitute cycle with estrogens, we use 800 milligrams pessaries, okay, per day, plus injected progesterone, that being subcutaneous, daily subcutaneous injections or intramuscular injections in alternate days.
And again, thank you so much for that once again, of course. All right. And well, I don't see any more questions, so we will be finishing, okay? But also, let me remind everyone that if you would like to get in touch with Dr. Nadia and, well, her team, I'm sure they will be more than happy to assist you and provide you even more details, and you will be able to use this link, and there is an option for you to get in touch with Dr. Nadia and her team. And in the meantime, we have this, sorry.
Piroloquinone. You got me with that. We don't use it.
Okay.
No, we don't use it. No, no, we don't use it. You got me, Christina.
All right. Thank you so much, well, for that question. And well, actually, Karen also came back with some details. So I have read a study that PQQ supplement works in a similar way as CoQ10, and I'm interested to know if you recommend.
If it's similar, really, I didn't know about that because we managed very well with coenzyme Q10. If the results are the same, you yes, go on, take it. Okay, there's no point in not taking it. Okay, so yes, you can use it. Okay, but studies up to now, what they recommend is coenzyme Q10. Okay, in 600 milligrams dosage.
And thank you so much for that clarification as well. And someone is typing, okay? So I just want to make sure whether it's a question or thank you. But as you know, we will be finishing. Any questions that you have, you can also direct to Dr. Nadia with the link I have just sent to you. And there are more thank yous coming up your way. Dr. Nadia, as always, it's
Thank
great
you.
to have you here.
Thank you for having me and giving me part of your time, okay, to explain some things. I hope I clarified some aspects and helped you in some other ones, okay?
You definitely did. And I'm sorry, but someone is just asking for clarification here. If you could take a look. CoQ10 is 600 before retrieval or transfer.
Before retrieval.
Okay, thank you for the
You're
clarification.
welcome.
And more thank yous coming up your way right here. And
Thank
so,
you so
everyone,
much.
thank you a lot for joining us to. I'm sorry, Emma has also added a question just now. I guess we can still answer that, right, Dr.
Yes,
Nadia?
yes.
Okay, so I have unexplained infertility. We have had one failed IVF attempt, transferring two grade 5 AA embryos. We have some frozen embryos. Our clinic is recommending a frozen transfer, but won't do any additional testing or suggest a different process. What do you think we should try?
Uh, I would I would study you a little bit more, you know, just study you for the failure. We usually, what we do is we see patients prepared for the failure. Okay, for example, if they prepared you in a substitute cycle, we just prepare you the same way as you were transferred, just to understand how the uterus was working that day. Okay, and understanding if we have to do anything else. I would recommend you to study your uterus a little bit better, fallopian tubes a little bit better, okay, and see if there are other causes, maybe an endometritis or some other factors that are altering that that result, okay, and giving you a negative result with very good embryos, okay, because if you get together very well in the lab, in the biology lab, and nothing is happening in your uterus, I have to think that something is happening in your in vivo lab, that it's your uterus and your fallopian tubes, okay, uterus meaning endometrial lining, and uterus itself, and the fallopian tubes. So I suggest you to just go on and investigate a little bit more.
And again, thank you for that advice. And there's a thank you from Emma here as well. And there's some more. So helpful. Thank you. Thanks a lot. And more,
Thank
I'll be
you.
honest. All right. And
Okay.
well, there's a question. Just a very easy one. So, can we get a personal virtual consultation?
Yes, of course, you can just send us an email, okay, to information @juanacrespo.es. In our web page, you can have the address. Our colleagues in the call center can give you all the information you need. We do online Skype consultations to give you some feedback on your case. You can contact us, and we will give you everything you need just to get an appointment. Okay.
Mm-hmm. Excellent. Can you repeat the email address once more,
Yes.
just in
It's
case?
information
Mm-hmm.
arroba juanacrespo.es. ES.
Excellent. ES. Mhm. Excellent. And remember that the link, I can send it to you as well if someone missed this email address. This is possible as well. All those requests will be sent directly to the team. Okay. And I'm sure they will be more than happy to provide you with some consultations, etc. And we will finish for today. But as I mentioned, thank you so much for everyone for your questions, Dr. Nadia. It's always a
Thank you,
pleasure. I know it's
Caroline.
not our okay. This is it. Thank you so much for that. Someone put it in the chat section. So if
Yes.
anyone,
Thank you. Info. Yes. Yes.
excellent,
Thank you so
fantastic.
much.
Exactly. Thank you for your help here. And remember that this has been recorded, so you will have a chance to watch this tomorrow. It will be available on our website, but it also will be available on our YouTube channel. And as you know, and someone contacted the clinic before, so thank you so much once
Thank you.
again. It's good to know then as well. And of course, remember that we will be back tomorrow at 8 p.m. UK time. There's another topic with another doctor. This time it will be about egg freezing with Professor Luciano Narbo from the UK. So please just go ahead and join us. I'm sure it will be quite interesting and useful for you as well. And Dr. Nadia, have a lovely evening. And
Thank
well,
you.
I'm very happy that you have came back here, and I'm sure that we will have some more of those events coming up very soon as well. Thank
Sure.
you so much.
Sure.
Take
Have a
care.
nice night. Bye
Exactly.
bye.
Take
Bye,
care,
everybody.
everyone.
Take
Bye.
care. Bye. Bye bye.